So the topic is approach to a case with difficult asthma. So how do you define asthma control? So there are two factors that you take into account when you define asthma control. One is what most of us understand, the symptom control. But important is that is not the only thing to be looked at when you're looking at asthma control. Other than the symptom control, you have to assess for risks, for factors for poor outcome. So this is a GINA table which we all are familiar with. First part is about symptom control. So it's about daytime symptoms, nighttime symptoms, how severely the activities of daily living are affected, and these are the main factors. So if it is more than twice per week daytime symptoms, need of relievers more than twice per week, or any night awakening in the past 4 weeks, or any activity limitation. So these are the factors which help you assess symptom control. If all this is controlled, it is called well-controlled asthma. If it is one or two of these, it's partly controlled. Otherwise, if 3 or 4 factors are there, it is uncontrolled. Now there is something called risk factors for poor asthma outcome. This should be assessed at diagnosis and thereafter periodically also. And one way is to measure FEV1 at diagnosis, and you can monitor that also. When you assess for these risk factors, there are 3 things that need to be assessed. The risk for exacerbation, the risk of fixed airflow limitation, and then the medication side effects which the patient is taking. So these are the 3 headings. And why we need to do so? Symptoms alone are not sufficient when you are assessing asthma. The symptom may be controlled, as we see, maybe even placebo or LABA alone or some, they are known to control symptoms at times because there could be various reasons for that. But what it leaves is an inflamed airway. So as you know, in relations also, if there is an undercurrent which is going wrong, then one day you can suddenly have a blast. So if there is inflammation which is going on, suddenly you can have an exacerbation out of blue, and you will say symptoms are well controlled, but he has landed up in ICU because the inflammation underlying was not getting controlled. Then symptoms could be because of some other reason. The child looks uncontrolled in terms of symptom, but the reason is something else. He is obese, cannot move around well, gets tired easily, and he feels that the chest condition is because of asthma. But the cause here is maybe obesity or the lack of fitness or laryngeal obstruction. So the symptom, if it is relieved, it may not be because of asthma control. If they are there, it may not be because of asthma alone. Anxiety, depression are also, they contribute to symptom reporting. And some patients have few symptoms despite low function. So there are problems with that symptom control. How to assess this risk factors for exacerbation? If a child is using 1 canister every month of SABA, of this, or the inhaled corticosteroids is not going right, the adherence is poor, the technique is wrong. So this is one setting where you can have a risk for exacerbation. Comorbidities, I just described obesity, chronic rhinosinusitis, reflux. It also mimics symptoms of asthma, food allergy and pregnancy. So these in adults, bigger children. And then you have, if the child is exposed to smoking, there is exposure to air pollution. So these also can create a scenario where a person is at risk for exacerbation even when the symptoms may seem controlled. Major psychosocial or socioeconomic problems can also contribute to this. Somebody who has a low lung function, especially if less than 60% of the protected, they are also at risk. And if the blood test suggests type 2 inflammation, that is eosinophilia or elevated FeNO. So these are the settings where the child or the patient is at risk for exacerbation, even when maybe the symptom may seem controlled. And the major independent risk factor for flare-ups is if the child has ever been intubated or been to an ICU, or there has been more than 1 severe exacerbation in the last 12 months. So these are the red flags that you should be familiar with and aware of in such children. So what I wish to say is that the risk factors increase the risk of exacerbation even if the symptoms are controlled. So they should be looked at. Then there is a risk factor for persistent airflow limitation that you have to look. So somebody is born preterm, very low birth weight, or there is a rapid gain in weight, or there is chronic mucous hypersecretion. This also creates a scenario of persistent airflow limitation. The lack of inhaled corticosteroids, exposure to, so some of that, this is overlapping, but this results in persistent airflow limitations, exposure to smoke, noxious chemicals, occupational exposures, and if there is a low FEV1 or the blood shows or sputum shows esophagia. Then when you assess such a child, look for side effects of the drug. This also needs to be taken care of. So it could be local side effects like a thrush, or it could be systemic side effects when you are using potent innate corticosteroids. Just a clinical scenario. An 8-year-old child, known case of asthma, on 400 microgram per day of Pediatrics, and along with that he is using salbutamol for the past also. Now, over the past 4 weeks, the daytime severe cough has been 3 times a week. The sleep has been disturbed once per week. There is a need to have salbutamol thrice per week. The child has missed school in the last 1 week, and there is an acute exacerbation requiring intubation 4 months back. So with this history, if I have to assess in those headings, I would say that in terms of symptom control, he is... Anybody? From the backside. Anybody? So what we had seen, he has day symptoms more than twice per week, need for relievers more than twice per week, the night sleep disturbed, the activity of daily living disturbed, he is uncontrolled. But then you have a risk of exacerbation also because he has been intubated. So there is a risk of exacerbation also. So how to approach such a case which looks uncontrolled? So as in clinical medicine, if you have a diagnosis and he is not responding to the treatment that is expected in that disease and the response that you expect, the first step is review your diagnosis. Be it asthma, be it TB, be it anything else, you have a diagnosis and what you are giving is not responding appropriately to that. The first thing is diagnosis. Now, the problem with diagnosis of asthma is it's a clinical diagnosis, and no single investigation will give this. So the two words are, it's a heterogeneous disease, there is a chronic airway inflammation, and then there are a set of respiratory symptoms like wheeze, somebody saying I have shortness of breath, chest tightness, cough. And the most important word here is they vary. There is variability of symptom, day to day variability, within day variability. That makes it more like asthma. It is not fixed, it varies depending on season, depending on even emotion, and depending on the day of the timing of the day. So that is asthma. So the diagnosis is based on history and evidence of variable airflow limitation. So whenever you have a diagnosis of asthma, document your reasons why you think it is asthma, and this is how Gina defines airway inflammation and hyperresponsiveness. But this alone is neither sufficient nor necessary to make a diagnosis of asthma. So what Gina says is that if you have a symptom complex which is fitting into a diagnosis of asthma, do a PFT. Confirm that there is a obstruction. But at times child comes to you in exacerbation, he is sick, you can maybe obviate this step and give acute treatment. The PFTs can wait after 1 to 3 months. So again, what I wish to emphasize here is, it's a clinical diagnosis. Even without PFT, you should be able to make a diagnosis. The rest of the things are fitting well. Just a word about role of PFT, as we have said, at diagnosis before start of treatment. But if the child has acute flare-up, it can be deferred, interval spirometry can be done, and needs to be repeated in case of diagnostic dilemma. And as our national guidelines would say, if there is no clinical ambiguity, you can start treatment even without spirometry. So this is not a must. If it is available, excellent. But if it is not available, then without this also you can make a diagnosis. Now comes step 2. Now you have confirmed that this difficult asthma is asthma. And you have to, the next thing is the Achilles heel here is the technique. Because we all know how to drink a drug, we all know how to have a tablet, but how to inhale a drug is something which is difficult. Even those who understand once, they forget. So it's a technique which needs repeated emphasis. In children less than 5 years of age, if you see, up to 3 years of age, we will have to use MDI with a spacer and a mask. After 3 years of age, we would prefer the child not to have a mask, because nose is meant to keep things out. So if you are inhaling something, it stops a lot of what you want him to reach the lower airway. So then again, choice of controllers can be an issue. It has to be shared decision making. The patient's preferences are to be taken care of. You cannot ask them to take MDI if they do not want to. Because at times, my own SR had asthma and she said, I cannot take an MDI because the spacer and all I cannot keep. I can keep a DPI in my pocket, it suits me, I will use that only. So ultimately, it's they who we have to, it's a shared decision making. and depending on the patient phenotype, his preference, we have to do that. And then for a particular device that you are using, you have to ensure that the patient is using the right technique, he is adhering to it, and cost can also be one of the factors. So all these are the factors which will help you decide which appropriate device to use. If you have advised a device which he does not want to use, then be assured he will not use it. So that's the reason why you have to ensure that. And when you have a patient who has a particular device, and I'll talk about the gold standard treatment, which is MDI, you have to ensure that he has understood what he needs to do. So try, it should not be multiple inhalers, try to use minimum number of inhalers, and ask him to demonstrate if he is coming for a follow-up. Note down the errors. First word, whatever he has done right, tell that. Next, whatever is not done right, explain that. Then demonstrate. Until and unless you demonstrate, words do not convey what you are thinking. Words will not reach where they are meant to reach. Demonstrate. Next step, ask them to repeat what you have demonstrated. And that is where you will know that he has understood what he has understood. But again, whenever he comes for follow-up, this simple step is not as simple as it seems. People tend to forget, people need to be, everything needs to be reinforced. So, first let them demonstrate, note down what is wrong, you demonstrate. If they have understood, now ask them to demonstrate back. Without this cycle, you will always have a problem in appropriate use of these devices. The next step is assess adherence. Now in pediatrics, it ultimately boils down to parents supervising that the child is appropriately taking it or not. You cannot, sometimes if the parents say, "This is a very intelligent bacha hai, sab kuch khud kar leta hai." But in that scenario, if he is a good child, because even at this age I am not a good patient. So to leave it to a patient is not good. So at least you can ask the parents to supervise whatever he is doing. Let the patient take himself. If the parents are around, it will add one more layer of supervision, and where it is likely that the adherence will be intact. Now another thing is, there could be, the diagnosis is asthma, no doubt about it, but there could be overlapping diagnosis, and there could be an alternative diagnosis altogether. So these are the two scenarios which you have to look at when you are looking at difficult asthma. And these are the pointers on history and examination which will tell you that this is not likely to be asthma alone. On history, if the child is not growing well, then it is something else. There would be variable V's, symptoms, everything will be there. But here, you look for some other diagnosis. It can happen in cystic fibrosis, the child is wheezing also. So if he is failing to thrive, think of something else. If it is wet cough, it is not dry cough, think of something else. If the patient has persistent or significant fever, think of something other than diagnosis. You have monophonic or localized wheeze. So if you have intrathoracic airway obstructions, they will also have a sound which is more in the expiratory phase, mimicking wheeze. So a monophonic wheeze can indicate that this is not asthma. Feeding difficulty, regurgitation, vomiting, all this can indicate that probably there is a reflux which is causing all these symptoms, and we are confusing it with asthma. Neonatal onset of symptoms, stridor, and absence of triggers. As I said, in asthma there is a lot of variability. If these with exercise, with viral infections, you should be cautious that this is something else that we are dealing with. If the child has clubbing or hypoxia, it is not just asthma. Malnourished, short stature, the child has diarrhea, ear discharge, severe infection, stridor. So all these will indicate. Then, if you have localized radiological lesion, again this will not be asthma. It could be something like atypical or maybe ABP, but it cannot be a typical asthma that you are looking at. Next step, identify treat comorbidities. So one is chronic rhinosinusitis. So if the child has symptoms of allergic rhinitis, so it's one airway from nose till into the lower airway. If there is an inflammation downstairs and you are not treating this one, then probably this symptom control will also be not as good. So if a patient has allergic rhinitis, treat that allergic rhinitis also. And sometimes the symptoms can almost mimic opacity. This also can help in asthma control. By losing weight, the symptoms can improve. GERD, by looking at nocturnal cough, vomiting. Adenoid hypertrophy. So here the symptom will be more like snoring rather than wheeze alone. And then psychological and psychiatric disorders are also associated. The sixth thing that we have to look at are environmental factors. If there is somebody smoking at home, then whatever dose of budesonide or budecort you may give, it is not going to help. So it's two-way treatment. One, you treat symptoms, at the same time you remove all those irritants, all those triggers, all those things. It's a combination of two. If you do not work on those triggers and those irritants, then the treatment, increasing the treatment alone will not help the child. So what you can easily do is at least smoking. Nobody in and around the house should be smoking. What else you can do? Probably if there is a seepage in the house, maybe that you can rectify. Some people say that okay, fine, having pets and that can also result in, but you have to weigh the benefits and the cost of removing the pet to which the patient or the family is emotionally attached. So ultimately it boils down to the how much discomforted the child is and how much you can make them go for it. If the symptoms are very less, occasionally any other pet, let him have it. But if it is so much that he is landing up in ICU probably, then that sacrifice also is to be made. So now, after all this, the diagnosis is reviewed, the technique is reviewed, other diagnoses are reviewed, and next come is upgrade the treatment. Before this, if you upgrade the dose of an MDI, you are going wrong. So this is the last step that has happened. So treating to you have to you have to assess whatever treatment is on, adjust, and then next time review the response. So it's a cyclical way, and when you have to teach and reinforce skills each time the patient comes, the inhaler skills, the adherence, and the guidance to self-maintenance education. So if you look at this control-based asthma management cycle, when you assess, you have to look at diagnosis, the symptom control and risk factors as we have just seen, inhaler techniques, adherence, and the patient preference. After this, the patient goes, and the next time, you have to adjust treatment depending on the control, the asthma medication, non-pharmacological strategies, treat modifiable risk factors, and then you have to review response against in symptom exacerbation, side effects, and patient satisfaction. Now, what is uncontrolled asthma and what is severe asthma? So the chart that we just saw confirmed that before that is uncontrolled asthma. Now the diagnosis is confirmed, technique is perfect, adherence is there, alternative or other diagnosis ruled out, comorbidities seen, environmental technique. So now what you're left with actually is severe asthma, where we need to actually work at. But so in terms of terminology, uncontrolled is something that there are frequent flare-ups and symptoms, but the child could be very well controlled even with low dose appropriate inhaled corticosteroids. He's not taking that, so that's uncontrolled. Difficult to treat. The disease is difficult, not the patient. Prescribing high-dose preventive treatment and contributory factors like incorrect diagnosis, technique, adherence, they can take care of this. And then you have severe asthma, where which is uncontrolled despite maximal optimized therapy and treatment of contributory factors, or that worsens when high-dose treatment is decreased. So it's a retrospective diagnosis. So if you have to look at severe asthma, one is optimized dose of inhaled corticosteroids and long-acting beta D agonist. Consider low dose maintenance. These are the things which you will need in a minimum, very uncommon group of patients. Most of them you will not. So most of the talk has been about things which you will need to do in all. So this is just an outline. There are options of oral corticosteroids, add-on treatment without phenotyping. Then phenotype-guided treatments are there, and non-pharmacological interventions are to be done. So as first step, optimize inhaled corticosteroids, LAVA, and then consider low dose maintenance corticosteroid, but then you have very significant side effects, even osteoporosis and all. Add-on treatment without phenotyping like tiotropium, theophylline, LTRAs. Phenotypic guided treatments are available, for example, for severe allergic asthma, things like IgE, for eosinophilic asthma, interleukin 5, anti-interleukin 5, sputum guided treatment, so and LTRAs for aspirin, exacerbated respiratory diseases. So these are the options which you will need in a very small number of patients. So people in the front row will probably need it, but the rest of the major audience that we have today, the talk is more or less done. So there are non-pharmacological interventions like comprehensive adherence promoting programs. So summarize, confirm the diagnosis, assess the inhaler technique, assess the adherence, exclude alternative and overlapping diagnosis, identify and treat comorbidities, look for environmental factors, and only then upgrade treatment. Thank you so much.
Thank you, Dr. Kamal, for such a comprehensive talk on such an important clinical topic.